Alright, so today's lecture is going to be over liver. It's going to be the second part of our liver series covering cirrhosis and a few other liver disorders. Here are your instructional objectives as usual. And here's the topic outline of what we're going to be covering today. So first of all, we're going to cover cirrhosis. And with cirrhosis, there's a lot of subtopics that we're going to be covering because as we know, cirrhosis affects many different parts of the body. So it's going to be a little bit of going in depth through each of those complications of cirrhosis. We're going to talk a little bit about alcoholic cirrhosis. We'll touch on some of the other causes for it. And then we'll go into hemochromatosis, Wilson's disease, and some of the neoplasms or liver masses. But to start off, we're going to start with cirrhosis. Now, we know that cirrhosis is a chronic liver disease. It's characterized by fibrosis, and as you can see here, it is pretty striking when you see a cirrhotic liver. It has lots of nodules. It's shriveled, kind of smaller than usual, and really the liver the hepatocytes are just dead, essentially. They get replaced by fibrous tissue, and it looks just damaged, worn out. And generally, by the time it gets to this point, cirrhosis, it is irreversible. In early stages, when it's not quite at this stage, you can do some things that can improve or reverse the condition. But it's not quite clear where that transition point happens between irreversibility and reversibility. So we have decreased blood flow through the liver. As you can imagine, all of this scarring and nodularity, fibrosis within the liver makes it really hard for vessels to kind of pass through and for blood to pass through those vessels. So the portal circulation, essentially all the blood kind of passes through the liver to detoxify. And so if you have a backup in this portal circulation, it causes widespread problems, some of which include ascites, which we'll go into, peripheral edema, splenomegaly, and varicosities. And we're going to go into these kind of one by one so we can talk about how they happen and how they present. Another kind of major event in cirrhosis is hepatocellular failure. And this leads to impairment of certain biochemical functions like albumin synthesis and clotting factor synthesis. So there's a lot going on with destruction of the liver, and we're going to go into things little by little. But first off, we're going to talk about what are the major causes of cirrhosis. The major cause, number one, is going to be alcoholic liver disease. So patients that drink, and we'll talk about alcohol-induced liver disease on the next slide. There are other conditions, probably number 2 and number 3 are going to be hepatitis, chronic hepatitis, so B and C. There are drugs that can cause cirrhosis and toxicity, including Tylenol and methotrexate. There is autoimmune hepatitis, which we won't really go into. Primary biliary cirrhosis and secondary biliary cirrhosis we will cover on the lecture with the gallbladder and pancreas, because it does have to do with the biliary tree. Hemochromatosis and Wilson's we will talk about later today. You can also get hepatic injection secondary to right-sided heart failure that can cause it, and pericarditis. And alpha-1 antitrypsin, which we mentioned in the pulmonary module, also causes cirrhosis. So if you see a patient that is young, never smoked, doesn't drink, and has emphysema and liver failure cirrhosis, think alpha-1 antitrypsin. Celiac diseases can be a contributing factor. And then NASH, which is starting to become one of the more prevalent causes of cirrhosis that Dr. A talked about in her lecture. So alcohol-induced liver disease is the leading cause of liver disease in the Western nations. In other parts of the world, hepatitis is much more prevalent. So those are the more common cause of cirrhosis. So what is alcohol abuse or dependence? So the frequency of alcohol, it's set around 10 to 15% of people who consume over 50 grams of alcohol per day. So if you want to put that in context, That's about 4 ounces of 100 proof whiskey, 15 ounces of wine, or 4 12-ounce cans or bottles of beer. And that's daily for 10 years. That is how much alcohol it takes in most cases to induce liver disease, okay? And it can be more or less. It's really person dependent. This is kind of a generality here. So alcohol is broken down by the liver, and because alcohol, the liver becomes problematic, it actually breaks down and increases the fat production. So the liver becomes fatty and enlarged. And as that happens, also get steatosis, which is, fatty liver. And usually at this point, the patients are asymptomatic. They continue drinking. Over time, it leads to what we call alcoholic hepatitis. And that is when you have this liver that is enlarged and painful. And if you do a liver biopsy, you'll see the quote-unquote Mallory bodies. It's more patho. On laboratory findings, see the classic AST and ALT elevation, but with AST greater than 2-to-1 ratio. You also see an increased alk phos and GGT, and some thrombocytopenia and hypoglycemia. At this point, when it's in the hepatitis stage, it is actually still reversible, but it is the most common precursor of cirrhosis, like we talked about. So the treatment, well, number one, whenever you have alcohol-induced liver disease, the number one treatment is going to be abstinence from drinking. Stop drinking. However, these patients are usually heavy drinkers for long periods of time, so we do have to monitor their withdrawal. And then when patients are in this kind of alcoholic hepatitis phase, you can add on corticosteroids to try to suppress the immune system and keep it from deteriorating further. And like we said, chronic alcoholism can lead to cirrhosis and liver failure. So in cirrhosis itself, some patients actually don't really have any overt clinical findings, especially early in disease when the liver is able to compensate, right? You still have good cells, you still have regeneration of the liver, and so patients generally don't have a whole lot of symptoms early on. Fatigue, some of the vague symptoms that patients get early on is like fatigue, some disturbed sleep, muscle cramps, and a little bit of weight loss. Clinically, the cirrhosis kind of progresses through stages, and as it becomes more fibrotic over time, the first off is compensated. So that means that it's making up for itself. It's not so far gone that it can't keep up, so you don't see a whole lot of findings there. Then we have this kind of in the limbo stage where you're compensated with varices. When we start seeing varices, we should start thinking that things are moving in the wrong direction. And then last but not least, we have decompensated. That is when the liver just cannot keep up with itself. Then it's when we start seeing most of the classic signs and symptoms of cirrhosis, including ascites, jaundice, encephalopathy, and variceal bleeding. We're going to go into most of these little by little. We're going to go through ascites, varices. We'll talk about these things, and liver failure as well. They kind of go hand in hand. So cirrhosis complications, right? Because cirrhosis of the liver causes lots of things, like we said. And I really like this photo from your textbook. It kind of illustrates all of the different things that are affected by cirrhosis. And we're going to, like I said, we're going to talk about these one by one. Portal hypertension has its own kind of subset of things that we see from it, including varices in different places. So esophageal varices, hematemesis, can also get engorgement or caput medusa from portal hypertension, where you get the engorged vessels around the stomach that kind of look like Medusa's head of snakes. You can get ascites, which is the belly full of fluid. You can also get hemorrhoids, which are essentially like rectal varices, right? Kind of in contrast to the esophageal varices. It all has to do with engorgement of the venous system and backup. Also, because there is backup to the spleen, you get splenomegaly, and that's pretty much what we're going to talk about for portal hypertension. as far as liver cell failure, there are many other things we're going to talk about, okay? Here is a little mnemonic. I'm not sure if you really need this mnemonic, but I put it here just in case. There is A, C, and then nine H's. So hypoalbuminemia, portal hypertension, hyperammonemia, hepatic encephalopathy, hepatorenal syndrome, hypoglycemia, hyperbilirubinemia, hyperestrogenism, and hepatocellular carcinoma. So, like we said, let's talk about portal hypertension. I'm sure you covered this in both anatomy and patho, but I'm going to talk about it really briefly. We know that the venous system, pretty much everything down here, is filtered up and through the liver, and that is through the portal vein. The portal vein enters the liver, and the blood is then filtered through the liver and exits as the hepatic vein and dumps into the inferior vena cava. Now, when we have a fibrotic liver does not allow clear and clean passage of the vessels and the blood flow through the liver because it's all scarred down. And so what happens is we get backup of the portal system, we get backup of venous blood, and it doesn't really have anywhere else to go except kind of trying to make its way around the liver or other places. Some of the places it goes to the superior and inferior mesenteric veins, so to the gut. It makes its way all the way down to cause hemorrhoids. It backs into the spleen, which causes splenomegaly. It also travels up and around, kind of bypasses the liver, makes its way to the esophageal plexus, and causes varices. And then it can also kind of reopen this periumbilical vein that gets closed after we're born, and it can cause the caput medusa. So that's kind of what we see here. You diagnose portal hypertension based on the classic signs. Paracentesis can help when we take some fluid out of the stomach. And we're going to talk about this also, the TIPS procedure that can be done to bypass the liver when we have severe backup, and usually in the presence of esophageal varices, we can do this TIPS procedure. So this is what we were talking about just right now. So like we said, when there's backup of blood in the portal system, it causes all sorts of issues, including esophageal varices, which can be life-threatening to a cirrhotic patient. So in the presence of these findings, patients that are not well controlled can have surgery where we do a transjugular intrahepatic portosystemic shunt. So essentially we connect the portal vein to the hepatic vein, and we put a stent in to keep it open so that the blood flow can essentially bypass a lot of the liver, and just kind of bypass all that fibrotic tendency. And so it reduces the pressure in the portal vein, thus reducing the portal hypertension, and the varices are less likely to rupture and bleed, which is kind of why we do it in the first place. Now maybe not the only drawback, but one of the major drawbacks to doing this TIPS procedure is that now you have a large amount of the blood supply that are not being filtered through the liver. And so we see an increase in hepatic encephalopathy because the toxins are not filtered out by the liver. Varices. So we talked about varices in the esophageal lecture. We are talking about it today, and we are going to talk about it again in the GI bleed lecture. So what are varices? We just talked about when the portal system gets backed up, the backup tries to kind of take a frontage road around the liver and ends up in the esophageal plexus area, and these veins become varicose, right? Varicose, just like you think of varicose veins in the leg, they're engorged, okay? And so when they're engorged there, they can essentially kind of pop out into the esophagus, and they can erode, causing bleeding. And variceal hemorrhage has a very high mortality rate because, as you can see in this picture, it's not just a little scab that you pick off and it just trickle bleeds. This can pour out blood, and patients can go into hypovolemic shock and death pretty quickly. For this reason, patients with cirrhosis should be evaluated, screened, and have surveillance of varices to prophylax, to try to prevent them from turning into this guy right here. And when the presence is found, we tend to start patients on a non-selective beta blocker to try to reduce the pressure in the venous system there. Like we said, it can cause a massive hematemesis. You can also get, since it's an upper GI bleed, some melena, dark tarry stools and it can also cause exacerbation of hepatic encephalopathy. If patients come in, we're going to talk about this in the GI bleed lecture, but initial treatment is stabilization, because these patients can be quite unstable, losing vast amounts of blood supply quickly. So you're going to give fluids quickly. You're going to get blood exams while you're resuscitating the patient. You're going to type and screen them, getting units on board to try to transfuse the patient if they need it. You're going to give IV antibiotics prophylactically and IV octreotide. This is to try to bring down that pressure and that's kind of clamp down those vessels. And in this case, you're going to get an emergent upper GI endoscopy, and we're going to see if we can ligate or burn off these bleeders in there. There are other kind of more drastic measures that can happen with these if the patient is severely unstable and can't tolerate the endoscopy. But essentially, that's kind of the algorithm of approach. Because of cirrhosis, you can also, like we said, get hemorrhoids and this caput medusa. Treatments for varices. Generally speaking, when we do the screening and surveillance, we will ligation or band them. So we put kind of a little rubber band, just like we do for internal hemorrhoids, to try to cut off the blood supply and things just kind of slough off. That is how we do it. We do it endoscopically. You can also do sclerotherapy, which kind of burns that off, but it's not always first line. It can control acute bleeding, however. We also we can give IV vasopressin as an alternative to octreotide, and like we said, IV octreotide. And then in very significant, hemorrhaging situations where the patient just can't tolerate, we can do this Blakemore tube, where we place the tube down the esophagus and essentially blow up this giant balloon here. And what that does is kind of tamponade or kind of put a tourniquet, I guess, on the bleeder as a temporary measure, so that we can kind of prepare for what needs to happen, get the patient resuscitated. And then eventually, most of these patients with severe esophageal varices have to undergo the TIPS procedure that we talked about. For screening purposes and surveillance, patients with cirrhosis, if they have compensated cirrhosis, so in the earlier stages, we usually do EGDs for surveillance every 2 to 3 years. Once they become decompensated, though, we do EGDs yearly and sometimes even more frequently. Here's a nice algorithm from Up to Date, kind of talking about what we just talked about and going step by step through the management of varices, but I will save this for when we talk about GI bleed. So moving on to another complication of cirrhosis is ascites. Now, everybody knows what a pregnant belly looks like. Ascites is essentially that, but full of fluid. And it's pretty striking. If you've seen any pictures, I have some pictures coming up. But when you see someone with ascites, you really can't miss it. It doesn't look like a normal, fat person stomach. It's full of fluid, and it's very protuberant. And this happens due to portal hypertension. You get this increased hydrostatic pressure that pushes fluid out of the cells and into the interstitium and the peritoneal cavity. And also, because the liver is responsible for producing albumin, and we have hypoalbuminemia, we have some reduced oncotic pressure, which also causes ascites. And it is the most common complication of cirrhosis. The clinical features, like we said, abdominal distension that you can't miss. There are some special physical exam tests that we can do to differentiate fat in the stomach or in the belly versus fluid. And one is a shifting dullness. So we percuss on the abdomen with the patient upright, and we percuss when they turn to their side, and the dullness should shift. We can also do what's called a fluid wave, where we kind of put our hand on one side of the belly and kind of tap on the other side, and we should be able to kind of feel the wave move and hit our hand on the other side. Abdominal ultrasound can detect fluid. It's very good at detecting fluid. You can also, especially early on, do a diagnostic paracentesis to determine whether it's due to the portal hypertension or to something else. There are other things besides cirrhosis that can cause ascites. However, cirrhosis is the number one cause of ascites. You also have to keep in mind that this fluid that doesn't belong there has a risk of getting infected, and we call that spontaneous bacterial peritonitis, and we will talk about that separately in a little bit because it does have a pretty high mortality rate, so we have to be aware of that. If you're unsure whether this ascites is due to cirrhosis or not, you can do what's called a SAG, or serum ascites albumin gradient, SAAG, and that essentially kind of helps you differentiate between a transudative fluid and an exudative fluid, and we know that in this case the acidic fluid from cirrhosis should be more of a transudative, lacking protein essentially, but you don't need to go too much into that. Treatment for ascites. Well, patients are unfortunately become pretty used to having fluid in their stomach. If it gets bad, let's say they have a diet, maybe they go out to eat a lot on vacation and they have like high sodium content in their diet, they can get more distended, and so we would definitely recommend a low sodium diet and diuretics, not and diuretics. We usually use a combination of furosemide and spironolactone. And then if it gets really uncomfortable or we're concerned about an infection, we can do a paracentesis to help alleviate some of that, and also to run it for analysis. And then we can do other things such as a TIPS procedure to try to reduce the portal hypertension, which would then reduce the ascites. So here's a picture. It's pretty striking. Like we said, it's very protuberant abdomen. Another telltale sign is kind of the absence of an umbilicus, or sometimes even like an umbilical hernia, like this. This is a very classic acidic belly. Like we said, there's other things that it can be. You definitely want to be sure that when you call something ascites due to cirrhosis, that it actually is that. Another complication that we're going to talk about with cirrhosis is hepatic encephalopathy. So hepatic liver encephalopathy, cephalo, we're talking about the brain here, okay? So the liver is responsible for metabolizing ammonia, okay? So it gets rid of these toxins within the blood. And so over time, the liver is not working as it should, and it's not normally detoxified, and so all these toxins continue to circulate within the blood, and they accumulate and reach the brain. And once they reach the brain, the patient starts exhibiting side effects from having all of this ammonia in their blood. You can also precipitate this. Certain states, like sedating drugs, infections and bleeding, can make this hepatic encephalopathy worse. How patients present: usually decreased mental function, they can be confused, have trouble concentrating, or even be so bad as to be in a stupor or coma. The classic, they will test you on this at some point, the classic physical exam finding for hepatic encephalopathy is going to be the asterixis. And I do have an image on the next slide illustrating this, but essentially it's like you hold the hands up kind of straight out in front of you, like you're telling someone to stop, and when you move the fingers, extend the fingers backward, the patient starts flapping their hands kind of like birds' wings. And very, very classic of hepatic encephalopathy. They also can get this horrible breath. It smells kind of musty, or like death, people describe it. The treatment for this hepatic encephalopathy is mainly lactulose. So lactulose, it helps with constipation also, but essentially it absorbs the ammonia and it does not allow it to reach the brain, so it keeps it in the GI tract and then excretes it, the ammonia. Another treatment, kind of the next step of treatment, is rifaximin, and that is an antibiotic that kills the bacteria, which are the responsible agents for producing the ammonia to begin with. And so they kind of kill that off, and that helps. One other thing that we try to limit in patients with hepatic encephalopathy, we know that with cirrhosis in general, we try to have a low sodium diet, but on top of that, with hepatic encephalopathy, we also try to limit protein because the protein causes increased ammonia levels, and we try to limit it to 60 to 80 grams per day. Here is an example of asterixis. So patient holds their hands out in front of them with their wrists extended backwards, and then the practitioner comes in and pushes the hands, and it causes the hands to kind of flap uncontrollably in front of them. The patient's not doing this, the body's doing it on its own. So this is asterixis. Moving on, another complication of cirrhosis is what we call hepatorenal syndrome. Now, remember we said that there's massive shunting of blood away from the liver, try to moving it around the liver. And because of that, we also get decreased renal perfusion. So the blood is not flowing through the kidney as it should. So over time, the kidney is progressively getting less and less blood, and the hypoperfusion causes vasoconstriction of the renal vessels and over time renal failure. And so essentially, the cirrhosis or the liver issue is causing kidney failure on top of everything. And it can also cause problems in the lungs as well. And what we see in this are the classic signs and symptoms of renal failure. So azotemia, oliguria, hyponatremia, hypotension, and low urine sodium. The only thing that treats this, as it does indicate in-stage liver disease, is going to be a liver transplantation. It doesn't have a very good prognosis once the cirrhosis reaches the point where it's causing hepatorenal syndrome. Like we mentioned before, whenever you have ascites, right, we can have a spontaneous bacterial peritonitis. So essentially, acidic fluid is hanging out in the belly, and anytime you have stagnant fluid in places in the body, is a risk for infection. And so what happens is that fluid essentially becomes infected, and the main agents that cause it are going to be E. coli, which is most common. You can also get Klebsiella and strep pneumoniae or Staph erythematosus. And we see a high mortality rate, 20 to 30%, in patients that have SBP. Okay. And it does have a high recurrence rate, so these patients can become sick very quickly. Generally, how they present, if you see in a vignette any patient with ascites, with abdominal pain and fever, you should think SBP, okay? And it leads to sepsis and deterioration. The diagnosis is established by collecting fluid, right? Tapping the belly, getting out fluid, and running analysis on it. Now, it's really hard to culture bacteria from fluid, from a paracentesis. So what we look for are WBCs, and more specifically PMNs. And that's what we're looking for. So diagnostic would be WBCs of greater than 500 and PMNs of greater than 250. And then, of course, if you do have a positive culture, even more so. But there are several culture negative SBPs as well. So we start them on broad spectrum antibiotics. These are IV antibiotics. Patients get admitted. And if it grows a culture, we can target the specific etiology. We should see clinical improvement. If not, and then we can repeat the paracentesis to look to see that the PMNs are decreasing. In patients that have recurrent SBP, sometimes we consider putting them on long-term treatments such as a kind of prophylactic Cipro or Bactrim to keep the bacteria from accumulating and forming infections in the acidic fluid. Like we said, the overall mortality rate is pretty high. It's up to 30% during the hospitalization and up to 70% by 1 year. That's pretty high. Another complication of cirrhosis is hyperesteranism. So the liver is responsible for metabolizing estrogen. So estrogen kind of circulates through the blood in both men and women. We have circulating estrogen. And because the liver is not working properly, there's damage, we get decreased catabolism of estrogen. So we build up estrogen in our blood. And that causes issues specific to hyperesteranism, including spider angiomas, which look like this. You can get them in any part of the body. They kind of look like a spider web, right? Palmar erythema, so redness of the palms. And then in men specifically, we tend to see what's called gynecomastia, which is excess breast tissue in the male breast area. And then because you have increased estrogen, you tend to get testicular atrophy as well in men. Last but not least, on the complications, I know we talk mostly about complications when we talk about cirrhosis because it literally affects almost every part of the body, right? Coagulopathies are common in cirrhosis. That's because the liver is responsible for synthesizing clotting factors. And so we tend to see prolonged PT and possibly even PTT with severe disease. There's also vitamin K is ineffective because it can't be used. So that also contributes to the coagulopathy. And we tend to treat these with FFP, fresh frozen plasma. And then the very, very last complication I want to talk about briefly here and then more in depth in a little bit is hepatocellular carcinoma. So anyone with cirrhosis has an increased risk of developing HCC. And this is, for all intents and purposes, liver cancer. Okay, when people talk about liver cancer, they talk about HCC. And it's present in 10 to 25% of patients with cirrhosis. So laboratory. As you can imagine, these patients with cirrhosis, once their liver has become cirrhotic, they're a chronic patient. They're in and out of the clinic routinely for monitoring of all of these sequelae from cirrhosis and preventative measures. They also have routine laboratory checks. Initially, when these patients first start with compensated cirrhosis, they don't have a whole lot of laboratory abnormalities, but as things start progressing, we start to see anemia. We also start to see even a lower WBC count because of the hypersplenism. We can see thrombocytopenia because of sequestration in the spleen, and also secondary to other suppressions and folate deficiencies. We tend to see prolongation of the PT, like we mentioned before. Blood chemistries tend to show elevations of AST, ALT, ALK-Phos, and even bilirubin. Serum albumin is decreased, and vitamin D deficiency is also mentioned. And there is a newer test called a FibroSure assessment that helps assess for liver fibrosis that we can do. Imaging, we use kind of a combination of different imaging studies. Ultrasonography, since it poses no radiation risk, is an easy way to kind of monitor the size and ascites, nodules, and kind of help screen for hepatocellular carcinoma. It does a pretty good job of that. If nodules are found, they're usually further characterized by CT or MRI. And then liver biopsy. So liver biopsy is going to be the gold standard for diagnosis of cirrhosis. They're performed usually laparoscopically, and you have to be kind of careful with patients because they tend to have coagulopathy, so they don't do too well. You have to be careful. You can also have them done endoscopically, the biopsies. Not everyone needs a biopsy to make the diagnosis of cirrhosis. You can kind of combine laboratory and imaging studies to help diagnose or exclude cirrhosis. Other tests, we do routine EGDs for the presence of varices and also looking for bleeding. How do we treat cirrhosis? Well, there's several different causes of cirrhosis to begin with. So the first thing we need to do is identify the underlying cause for the cirrhosis. For example, if alcohol, which is most common, if alcohol is the cause of the cirrhosis, well, then we have to abstain from alcohol. If we have Hep B or Hep C as the underlying cause, then there are some newer drugs out there that can help cure patients. And so that's the first thing we have to do with cirrhosis. We also want to avoid anything that is hepatotoxic or medications that have to be synthesized by the liver, things like acetaminophen. The diet, we want to eat adequate calories, kind of keep track of the protein and sodium. And then really the rest of the treatment of cirrhosis kind of aims the treatment at managing any of the complications that come up, because not every cirrhotic patient has every complication. Some have some things, others have others. And so, like we mentioned before, the more serious complications are going to be variceal bleeding, ascites, and hepatic encephalopathy. The only cure for cirrhosis is going to be liver transplantation. That is the only cure. Patients are not eligible to have a liver transplantation if they are still using alcohol, if they're still drinking. So they have to be abstinent from alcohol for more than 6 months to be eligible for transplantation. And there's a long list for liver transplantation, and it's by region. So some patients get so desperate on the liver transplantation list that they actually move to different parts of the United States to get into a region that has a shorter list. So it can be quite competitive. You have to be pretty sick to be eligible to receive a liver transplantation. And the decision really has to be based on whether or not the transplantation is going to improve their quality of life, whether they are going to be able to tolerate it, and that they have no contraindications to getting the liver transplantation. And we base transplantation on what we call the MELD score. It kind of prioritizes patients, and we'll cover that in a minute. So we have really two kind of classifications that we look at when we talk about cirrhosis and kind of liver disease. And first is the Child-Pugh score, and this helps us kind of determine the survival rate, or kind of the how bad the liver disease is. And we combine factors of presence of ascites, bilirubin, encephalopathy, INR, and albumin, and we can categorize them as either a Child-Pugh score of 1, 2, or 3, and they puts them in the class A, B, or C. And they get those number of points. So 1, let's say they have no ascites, but their bilirubin is from 2 to 3. They have encephalopathy, mild to moderate, and the INR ratio you can see adding up. So this is 2, 2, 2, 2, and then we put them into a class. And so anyone from 5 to 6 points has the least severe liver disease. It has about an 85% 2-year survival rate. And you get down into the 3s, when you get a lot of 3s in here, and you get into class C, 10 to 15 points, you have only about a 35% 2-year survival rate. And so that helps kind of classify them. Like we mentioned before, the model for end-stage liver disease, or the MELD score, is the score that we use to prioritize transplantation candidates. And so we use lots of different calculations here, including bilirubin, INR, creatinine, and then there's a constant. And we add all that together, and it gives us a numeric value. The numeric value is between 6 and 40. So 6 is the constant, right? So that's if everything else is normal, that's the lowest score you can get. That's the least ill. And 40 is the most gravely ill. So anything up towards the 40 level, they are higher on the list. They're like 1, 2, 3 on the list for transplantation. So wrapping things up, once a patient starts developing complications of cirrhosis other than varices, they are said to have decompensated disease, which is associated with a higher morbidity and mortality. Esophageal varices are bad. We got to get on top of them early, screen for them, and treat them quickly because patients can decompensate very quickly. Ascites, salt restriction, diuresis, SBP, high mortality rate. Look for abdominal pain and fever, sometimes mental status change. If it's not treated early, mortality is high. And I really, really like this chart from Osmosis that kind of helps see the big picture after we've gone through all these little things, to see the big picture between compensated and decompensated cirrhosis, kind of the laboratory findings that you would see, the different manifestations of cirrhosis that we've discussed, and kind of how they present and where they lie. So this would be a good time for you to take a quick break to get up, stretch your legs, and then come back and finish out this lecture. All right, so the next topic we're going to be covering is hemochromatosis. And hemochromatosis, I don't know why. Hemo is blood. Chrome makes me think of a metal of some sort, right? Chrome. And atosis, I don't really know what to do with that. But essentially what it is iron deposits, abnormal iron deposits in different parts of the body, namely the liver. And it is an autosomal recessive disease. It's not very common. I've never seen it in clinic or ER or GI. I've never seen hemochromatosis, but it is out there, and it is a mutation of the HFE gene. And it's high iron, right? So iron, Fe for iron. So we have excessive iron absorption in the intestine, and that leads to accumulation of iron. So everybody absorbs a little bit of iron from the diet that we eat. But in these folks with this autosomal recessive disease, they absorb too much iron, and so the body doesn't know what to do with all this excess iron, and so it just starts storing it in different organs. And so you get this iron where it doesn't belong, starts causing fibrosis and free radicals that start damaging the organs. The liver is the primary organ where these molecules of iron are deposited, but other places that can be deposited are the pancreas, the heart, the joints, the skin, and other places here. like the hypothalamus and parathyroid, thyroid area. It is inherited, so we do want to screen patient siblings, and we want to make the diagnosis as early as possible before you start having complications, to try to limit the complications and improve survivability. Like I said, most patients are asymptomatic. They don't have any symptoms early on. Kind of the first things that you start to see are mild elevation of AST and ALT from the inflammation of the liver. And you should get iron studies. If the iron level is elevated, you should order a liver biopsy to confirm the diagnosis. Later, clinical manifestations, if we don't catch it early enough, are arthropathies, kind of like an osteoarthritis with the deposits in the joints. Hepatomegaly from the deposits in the inflammation in the liver. Skin pigmentation, these patients tend to have a bronze skin color, kind of like they did too much fake tanning. And they can also get cardiac enlargement, and a lot of patients tend to have concurrent diabetes because of the effects on the pancreas. And so we tend to call them bronze diabetes. Bronze diabetes is what we call it. And these patients also, especially men, because of the deposits, can also have erectile dysfunction. You can also get, this is considered primary hemochromatosis, the genetic condition, but you can actually also get a secondary hemochromatosis in patients that have multiple transfusions, blood transfusions. They can also develop kind of a secondary hemochromatosis. So cirrhosis is a major complication. You can also get cardiomyopathies, like we said, diabetes, arthritis, and all the other things, the bronze-like appearance. Laboratory findings mainly revolve around liver and iron, and so you'll have markedly elevated serum iron and ferritin, and an elevated iron saturation, but you'll have a decreased total iron binding capacity because it's all taken up by the iron. Liver biopsy is going to be the diagnostic test of choice to diagnose. You also, once you make the diagnosis, want to confirm testing for HFE mutations, and plus or minus MRIs and CTs that can show changes over time. So how do we treat these patients? Well, we want to avoid iron-rich foods, no alcohol, no vitamin C, no raw shellfish, and they also want to perform, it's actually quite archaic, but we do repeated phlebotomy, so we bleed them, which bloodletting used to be kind of an archaic treatment we used to do for all sorts of diseases, but it actually works for hemochromatosis. So these patients usually initially go for weekly phlebotomy sessions where they have 1 to 2 units removed, and those are in symptomatic patients. And then once you get them under control, then usually continued for a few years, and then once the depletion of the iron has been achieved, then they can do kind of this maintenance phlebotomy every 2 to 3 months, and we kind of keep an eye on their ferritin levels and things like that. So it's interesting, right, that we still use that treatment and it works well for this. We also give patients PPIs, which help reduce iron absorption in the gut, and we treat any complications that come of it. The treatment, the in-line treatment, the only thing that can cure it is a liver transplant in advanced cases. And so this is a patient with hemochromatosis. As you can see, they have this bronze-like appearance. And I put this picture here. He does not have hemochromatosis, but that's the look that they tend to have, that bronze-like appearance. And then I really, really like this this drawing here of Iron Man, and it shows you kind of all the different things that it can cause. Wilson's disease kind of gets lumped into the other liver disease category, and whereas hemochromatosis was an excess in iron, Wilson's disease is an excess in copper So that's why I put all these little pennies here. And it causes a different picture, but it is also a rare autosomal recessive disease, and it's a disease of copper metabolism. The body cannot properly metabolize copper. Usually we have copper that's excreted into bile, but in this case, the copper accumulates in the liver. And because of this, it causes free radical formation and it causes hepatocytes to die. And over time, that can lead to liver cirrhosis and copper buildup. Most often, these patients appear, after the age of 5, kind of in childhood and adolescence, although cases tend to happen anywhere between ages 3 and 55. And pretty much any kid that comes in with acute hepatitis or splenomegaly or hypersplenism, Coombs negative hemolytic anemia, any of those things, you should look for Wilson's disease. You should also look for it in any person under 40 years of age with chronic hepatitis or acute liver failure. So clinical features are all due to copper deposition. So like we said with iron, we got all this extra stuff going on, all this extra floating around. So the body stores it in different places. And some of the places that they tend to store copper are liver, first and foremost. This is the most common initial manifestation, those liver disease. And they can get hepatitis, cirrhosis, and fulminant hepatic failure. Another one that they love to test on, and is very pathognomonic for Wilson's disease, are these Kaiser-Fleischer rings, which is this kind of dark copper-colored ring around the iris of the eye. And this is pathognomonic, like I said, and you can see it pretty clearly on most patients. Other findings that we tend to see, it tends to deposit in the brain. So we see findings due to copper deposition there, including kind of this Parkinsonian symptoms where they get these tremors, abnormal movements, drooling, lack of coordination, and then psychiatric disturbances, so depression, neurosis, personality changes, and even psychosis. It can also be implanted in the kidneys. You can have problems with that as well. Here's another example of those Kaiser-Fleischer rings. Very pathognomonic. Most every case of Wilson's disease that I've seen, I've never seen it in real life, but when I'm talking about vignettes for testing purposes, they almost always mention those Kaiser-Fleischer rings. Whether they call it that or not, they're going to mention the ring around the iris. Diagnosis is made by hepatic disease. You get a liver biopsy. And then also a decreased serum ceruloplasmin level. And this is what kind of carries the copper breakdown. And since there's no copper breakdown, it carries nothing, so it's decreased. And then if you diagnose it, you should look at first-degree relatives for screening purposes as well. How do we treat Wilson's? Well, we have to restrict dietary copper. There is copper in the food that we eat, especially shellfish, nuts, mushrooms, chocolate. And then we use chelating agents. For example, penicillamine, and what it helps remove and detoxify copper deposits. We also use things like zinc, which helps prevent the uptake of copper. And liver transplantation is going to be if they're unresponsive or later on with fulminant liver failure. And here is my favorite med comic comparing the two, hemochromatosis and Wilson's disease. It might seem kind of easy, straightforward now, but give it a year and a half when you take your pants. If you don't study this again or try to recommit it, find a way to remember it, you might get confused between the two, so please think about it. Our last section for this lecture is going to be liver masses, and just for the sake of thoroughness for this lecture, so we talk about cancers or masses, tumors within the liver. We're going to be talking about primary liver masses, so masses that originate in the liver, but by far secondary liver tumors are way more common than primary. And the places that tend to metastasize to the liver are the colon, the pancreas, the lung, and the breast. But we're not going to talk about secondary liver masses. We're going to talk about primary. And the first ones we're going to talk about two different benign masses within the liver. The first is a hepatocellular adenoma. And we tend to see these kind of in younger women, 15 to 40 years old, and it has a high association with oral contraceptive use. So if you see a vignette that talks about a mass in the liver in a younger woman with oral contraceptive use, you should consider it. It has a very, very low malignant potential, so essentially benign. The only thing that can happen with these adenomas, they can become large and rupture, and they can cause bleeding. So that's one thing. We usually make the diagnosis incidentally by CT. We can also see it on ultrasound and then hepatic arteriography, although that is invasive. The main thing that we do, because since it's tied to oral contraceptive use, is discontinue oral contraceptives. And then if the tumor is causing significant pain, or if it becomes larger than about 5 centimeters, then we would remove it to help prevent a rupture. The most common benign tumor of the liver is called a cavernous hemangioma. And these are vascular tumors. The size of the tumor tends to increase with pregnancy or again, use of oral contraceptives. And symptoms, a lot of these things are found incidentally when we do scanning or images for other reasons. However, patients can present with right upper quadrant pain or a mass on physical exam. Complications are pretty rare unless the tumor is very large, and that includes rupture, some obstructive jaundice if it's close enough to the biliary pathways and things. And we diagnose, with ultrasound, CT scan, and biopsy is contraindicated because of the risk of hemorrhage. Most cases do not require any treatment, but we do consider resection if the patient is either symptomatic, painful, or if they have a high risk of rupture, large tumors. The mass that I'd like to focus on the most for the next few slides is going to be hepatocellular carcinoma. Like we said before, if someone says they had liver cancer, they're probably talking about HCC. It is malignant and it is a hepatoma, what they call it. It accounts for more than 80% of primary liver cancers. It's not as common in the United States, but it is has a lot of mortality worldwide. And there are two pathologic types, not necessarily important for ICM purposes, but they are associated with hepatitis and with alcoholic cirrhosis. Like we said, cirrhosis is a major risk factor. HCC develops about 10% of cirrhotic patients. There's also some chemical things and other things that can make you more prone to getting HCC, but by far cirrhosis is the most common. Patients tend to have abdominal pain or painful swelling of the liver. As with other cancers, they have the generic kind of systemic symptoms of weight loss, anorexia, and fatigue. And then because these tumors are growing within the liver, you have the same kind of chronic liver disease problems of portal hypertension, ascites, jaundice, and splenomegaly. They can also cause some paraneoplastic syndromes, aside from the other things that we talked about. So HCC is likely in a patient with cirrhosis who has a palpable liver mass and an elevated alpha fetoprotein level, AFP. Liver biopsy, it's required for a definitive diagnosis and staging. You want to get a piece of the tumor to see, not only the patient's long-term survival rate, but also determine which treatment is best for them. You also want to do serologies for chronic hepatitis, LFTs, coagulation testing. Imaging studies, we use generally a multiphasic helical CT or MRI. Ultrasound we use for screening, but it's not as sensitive and it's very operator dependent. And then, like we mentioned before, AFP or alpha fetoprotein is useful in screening. It's elevated about 40 to 70% of patients with HCC. And it also helps monitoring response for therapy. You should see that going down as we treat the patient. So it is recommended that patients with chronic Hep B with cirrhosis caused by hepatitis C or alcohol, that they have surveillance or screening done for hepatocellular carcinoma. And we usually do this by means of ultrasound and AFP levels every 6 months. And we're looking for an AFP of 20 or more, that is indicating that it could be HCC. So we do surveillance. I know in the clinic that I worked at, we would have these patients in every 6 months, and we would screen them for hepatocellular carcinoma. Lastly, treatment. So liver resection, not very many patients have resectable tumors, but if we do, we can take out part of the liver or the tumor, and that is curative in some cases, not often. Liver transplantation, if we can diagnose early enough, then there are some other ablations and things that can be done. If it is resectable, there are 25% of patients are still alive at 5 years, but if it's unresectable, it's less than 1% at 1 year. That is very low. And with that grim note, we will end our lecture. Make sure that you go back over cirrhosis and liver disease. I did put all of the osmosis videos for you in your playlist on your Blackboard site. I looked through those and they're actually really good. They have some really nice drawings and illustrations of some of the things that we talked about today. So I would recommend that if at the end of this you're still a little iffy, go through and spend some time watching those videos. And that'll help solidify what we talked about here today in this lecture. Once again, I want to thank you for your attention, and I will see you later in class.